there will be no discussion about Priapism without the talk of the god of fertility, Priapus, whom Priapism is named after. So we'll be using this outline to discuss Priapism. Now, Priapism can be defined as persistent, painful penile or clitoral erection that lasts longer or is unrelated to sexual desire or stimulation and is not relieved by orgasm. For the sake of this discussion, we'll be discussing Priapism as it relates to painful penile erection. Now, basically, it arises from dysregulation of the mechanism surrounding erection, basically tumescence, rigidity, and flaccidity. Though relatively uncommon worldwide, it has a high incidence among those of Black race, mainly due to the higher incidence of sickle cell disease or trait amongst Blacks. Now, like I just said, the earliest cause of Priapism is sickle cell disease. There are several other causes, including drugs, tumors, trauma. Now, any erection lasting longer than 4 to 6 hours is said to be priapic, and usually after about 6 to 8 hours, pain ensues. The commonest complication of Priapism is erectile dysfunction, and 90% of those that end up with this complication tend to occur after divided into ischemic and non-ischemic. Ischemic also known as veno-occlusive and non-ischemic also known as arterial or high flow. There's also the stuttering, which is basically recurrent Priapism. Ischemic Priapism is a urological emergency with the sequelae of penile fibrosis and loss of erectile function. Thus, the goal of management is to achieve penile detumescence and preserve erectile function. Treatment of Priapism follows a stepwise pattern, and prevention of future episodes of Priapism is the goal, and this is dependent on the etiology. Now, the term Priapism, as earlier said, has its origin from the Greek god Priapus, who was worshipped as the god of fertility. By way of some brief history, we'll talk about erection a little bit, where Aristotle initially said that erection was as a result of influx of air into the penis. But Leonardo da Vinci debunked this assumption when he discovered large amounts of blood in the erect penis of men that were hanged. Parry described the penis as being composed of several layers, nerves, veins, arteries, and corpora. And he was the first person to actually deduce that the penis was made up of different components and not just two tubular structures. Now, Hunter and Dionys stressed the importance of retaining blood in the penis for you to maintain an erection. The background of our present understanding of erection and, of course, Priapism came around the 1980s and 90s. The first account of Priapism known was in the Lancet Journal, where most first accounts have occurred. Now, the natural history of Priapism was, first of all, described by Frank Heman Sr., but properly elucidated by his son, Frank Heman Jr., who proposed that venous stasis, increased blood viscosity, and ischemia were responsible for Priapism, and emphasized that failure to correct these abnormalities in the pilar environment was essentially responsible for non-response to treatment. Now, non-ischemic Priapism was described by Burt in 1960. Edmond and colleagues described stuttering Priapism when they noticed recurrent episodes, short-lived episodes of Priapism in Jamaican sickle cell patients that they studied. So in discussing the functional anatomy of the penis, we're going to talk about the penis that is composed of 3 cylindrical structures, the ped, corpora cavernosa, and the spongiosum, covered by a loose subcutaneous layer and skin. So basically it's made up of, the layers include the skin, the dartos fascia, the box fascia, then the tunica albuginea. Now, the length of the penis varies during the flaccid state and the erect state, and is highly dependent on the age of the patient, sometimes on the race, and also on a few other factors. Different people have measured and proposed different lengths of the penis, with the flaccid length being controlled by the contractile state of the erectile smooth muscle, and it varies highly depending on the patient's emotion and outside temperature. The tunica albuginea is the covering of the corpora cavernosa. It is very important because it is majorly involved in the veno-occlusive mechanism that maintains the erection. Now, it is a bilayered structure composed of an inner layer and an outer layer. The inner layer has circular fibers with intracavernous pillars radiating from it. These pillars are struts that act to maintain the support of the penis. Now, it has the spongy tissue, which are numerous. The outer layer is oriented longitudinally, extends from the glans penis to the proximal crura. Now, it's the outer layer of the tunica of Virginia inserts into the inferior pubic rami, but of note is the fact that it is absent between the 5 and 7 o'clock positions. This is important because at this point is where majority of implants following penile fibrosis tend to extrude. Now, emissary veins run between the inner and outer layer of the tunica of Virginia, and that's why earlier I said it's involved in veno-occlusive mechanism. The external penile support of the support of the penis is basically externally by the fundiform ligament and the suspensory ligament. Now we have a set of the corpus cavernosum, which are the erectile bodies, are paired cylindrical structures located with spongy tissue within them. Now they usually start as crura, originating in the undersurface of the ischiopubic rami. Initially, there are two separate structures, but they merge at the pubic arch to form one up to the glans. There's an incomplete septum between both of them. The terminal cavernous nerves and helicine arteries are intimately associated with the smooth muscle of the tunica of Virginia. All this is important because they play a huge role in maintenance of erection. And as such, they play a huge role in priapism. Now, the spongy tissue of the corpus cavernosum is made up of sinusoids, which are larger in the center and smaller in the periphery. In the flaccid state, blood flows slowly from the central to the peripheral sinusoids, and the blood gas level at this point is similar to that in venous blood. However, due to large influx of blood via the dorsal penile artery, during erection, the blood gas levels are similar to those of arterial blood. The corpus spongiosum and the glans penis have similar anatomy to that of the similar structure to the corpora cavernosa, but they have smaller sinusoids. Now, the corpus spongiosum surrounds the urethra from the bulb to the penis. It has a thinner tunica because it lacks the outer layer, and it also lacks the intracorporal struts. This is important because you need to maintain a low pressure during erection that also allows for emission of spermatozoa following ejaculation, forceful emission actually following ejaculation. Of note is the fact that the spongiosum and the glans tend to be spared during priapism. Now, the arterial supply to the penis can basically be divided into the external or outer or superficial system, and then the deep system. The external is responsible for supply to the penile skin, and this is independent of the supply to the erectile bodies. The external is by the superficial penile, is by the external pudendal arteries, while the internal is by internal pudendal arteries. Of note is that the internal pudendal gives rise to the penile artery, which divides into the bulbo urethra that goes to the corpus spongiosum, and then the dorsal artery and cavernosal arteries. This dorsal artery runs along the top of the corpora cavernosa, giving out the cavernous branches which form the deep artery of the penis, and the circumflex artery to end up supplying the glans penis, and ends up supplying the glans penis. The venous drainage of the penis is via multiple interlacing veins. Basically can be divided also into the drainage from the skin and subcutaneous tissue, drainage from the penis, and drainage from the penis, that's the glans and distal two-thirds of the cavernosa, and then drainage from the infrapubic penis. The drainage from the skin is via the superficial dorsal vein, which goes to the saphenous vein, and then joins the Santorini plexus. The drainage from the penis, the glans and the distal two-thirds of the cavernosa is via the deep dorsal, the emissary veins that go to the deep dorsal vein, which combine with the circumflex and periurethral veins to enter into the saphenous. And then the spongiosum is via the internal pudendal. So the sensory innervation of the penis is via the dorsal nerves of the penis, while the somatic is via S2, S3, and S4. Of note is that the parasympathetic supply is responsible for erection, while the sympathetic is responsible for the tumescence. Lymphatic drainage of the penis is via the superficial, is from the skin of the penis is to the superficial inguinal and subinguinal nodes, while that of the penile shaft goes directly to the inguinal nodes. So this is just a cross section of the showing us the communication with the deep artery right stuck in the middle of the cavernosa, and the communication between the deep dorsal vein, the dorsal artery, and the nerve at the border between the corpora cavernosa and the tunica albuginea. So by way of conclusion or summary, we should know that the corpora cavernosa are basically the erectile tissue of the penis, which are covered by the tunica albuginea that protect it and provides rigidity and support. Of course, the tunica albuginea is also involved in the veno-occlusive mechanism. Smooth muscles allow for the inflow and outflow of blood. The outer muscles include the ischiocavernosus and the bulbocavernosus muscle, where the ischiocavernosus help with to hasten blood supply and thus hasten erection and provide rigidity during erectile phase. And the bulbocavernous muscle compresses the bulb to help expel semen into the vagina. The corpus spongiosum is responsible, it houses the urethra and allows for forceful expulsion of semen during ejaculation. The glands acts as a cushioning effect to lessen the impact of the penis of the female on the female organs, and also provide sensation to the penis. Thank you very much. My colleagues will continue from where I stopped. Thank you.
Thank you very much. Please stop sharing your slide. We are going to listen to Dr. Abdullahi Sudi. Is going to tell us about epidemiology and pathophysiology. Dr. Sudi, please share your slide.
Yeah, thank you. Thank you, Prof. Can you hear me?
Yes, we can hear you.
Good evening. Okay, good evening, Prof. And senior colleagues and colleagues. I'm going to share my slides. Can you hear me? Can you see my slides, Prof?
Not yet.
Yes. Prof, good evening, Prof. Can you see my slides, sir?
Not yet. Okay, let me share for you.
Hello, sir.
Now I'm sharing your slides. Are people seeing it?
Yes.
Okay, so carry on with your, carry on with your presentation.
I'm trying.
Carry on, I'm sharing your slide.
Okay, Prof. I have some problems here.
Can you hear me now? I have a lot of interruptions.
I can hear you, Prof. Okay, Prof.
Professor, okay.
Okay, sir.
Yes.
Okay, sir. Yes, sir. I can. Okay, thank you, Prof. Good
I'm
evening,
sharing your slide.
Professors. Yes, Prof. I can
Go
hear
ahead.
you, Prof. I can see the slides. Thank you, sir.
Go ahead now. I'm sharing your slides.
Yes, Prof. Something is covering it. Something came up and it's covering my slides. I cannot see from my end here, sir.
Is any other person seeing my slide?
Yes, your
Okay.
slide is clear from this end.
Okay. We can move to the next presenter.
Okay, sorry.
Okay, we can take you.
Something pop up and it's covering my view. I can't see the slides, sir.
Okay, don't worry.
Okay.
You go back.
Yeah, okay.
Click stop sharing because then let's take Dr. Danagogo. Taking off on etiopathogenesis. Dr. Danagogo, you can share your slide now. Put it in slides view. Shows slideshow. Okay, go ahead.
Thank you, sir. Good evening, senior colleagues and colleagues. I'll continue the discussion discussing etiopathogenesis of Priapism using this outline. Priapism generally are classified into high flow and low flow. Low flow is also called veno-occlusive, and then the high flow is also called arterial. The low flow of veno-occlusive priapism is the most common priapism, as mentioned earlier. And the most common cause are hematologic dyscrasias, which is mostly sickle cell disease, as we know. It is over 40% of patients with sickle cell disease will experience either a full-blown priapism or stuttering priapism in their lifestyle. Other hemoglobinopathies like hemoglobin C, X, hemoglobin C, thalassemias, hereditary spherocytosis can also cause ischemic priapism. Thrombotic states, asplenia, use of erythropoietin, even use of heparin in patients undergoing hemodialysis has been associated with ischemic priapism. Hyperleukocytosis, and then patients who have metastatic deposit from primary tumors like tumors in the bladder and prostate. Metastatic deposits from the lungs have also been reported to cause priapism. The treatment of erectile dysfunction can also cause priapism, where use of intracavernous injections like papaverine, aprostadil, and a combination of these with phentolamine has been seen to cause priapism. The injectables are known to cause more priapism than the oral agents, and all the oral agents, the oral phosphodiesterase 5 inhibitors, have been implicated in priapism. Stuttering priapism usually lasts less than 4 to 6 hours and is self-limiting. Patients who have experienced stuttering priapism are likely to experience priapism. Other agents like alpha-adrenergic blockers, tamsulosin, which is regularly used in our practice, has also been reported to cause priapism. Recreational drugs like alcohol, crack cocaine, marijuana have also caused priapism. Neurogenic causes like spinal cord injury, caudal equina syndrome, medication agents, and metabolic conditions known to cause priapism. And infections also causes priapism. Non-ischemic or arterial priapism, which is less common, usually result from unfettered blood flow from the arterioles into the cavernous bodies usually causes a painless erection. It is not usually a field tumescence. It could result from blunt injuries like straddle injury, kicks to the perineum, sexual trauma, and birth canal trauma have also been known to cause material priapism. Penetrating injuries from needle penetrations or aspirations, and even shunting procedures to treat veno-occlusive priapism may result in non-ischemic priapism. In surgical procedures like cold knife ureterotomies and Nesbit corporoplasties have also resulted in priapism. Metastatic deposits too have been reported to cause non-ischemic priapism. Now, the non-ischemic priapism usually results about 24 hours or more after the initial trauma or injury that caused it. Now, it's thought that the nocturnal tumescence that may result about 24 hours from the initial injury dislodge the clots that occluded the injury to the arteriole, now leading to blood flow directly from the arteriole into the corporal body. The fistula will form a pseudocapsule in about 4 to 6 weeks from the initial injury. Now, there have also been non-fistula arterial priapism have also been recorded, and this occurs from dysregulation of the cavernous inflow. Like I said, it's a complication. The molecular basis of ischemic priapism is regulatory vasorelaxatory mechanisms. When there is persistent erection, there is, of course, tissue hypoxia leading to acidosis. There's distortion of the endothelial membrane, which will lead to lipid peroxidation and increased oxygenase of expression, increased release of oxygen free radicals. These will cause damage to the cavernous tissue and then cause necrosis, which will heal by fibrosis, and this may now cause erection, which is a common and feared complication of priapism, for which, in order to prevent that, early treatment should be instituted. Now, in association with the endothelial injury, there is release of cytokines transforming growth factor beta, which ordinarily should regulated release due to oxidative stress, causes the severe scarring and has been associated with the corporal progression, the corporal fibrosis that occurs during priapism. Now, sickle cell disease is worth mentioning because it is most common cause. Several studies were cited, report about 30% of cases of priapism. 30% of patients who have priapism were those who had sickle cell disease. We know that in sickle cell disease, due to hypoxia, there's sickling of the red blood cells. This sickling of the red blood cells will lead to hemolysis. The hemolysis will lead to the release of hemoglobin into the plasma. The hemoglobin reacts with nitric oxide to produce methemoglobin and nitrates, thus mopping up the nitric oxide. So the vessel dilator nitric oxide is converted to an inert state. Now, sickled erythrocytes also release arginase, which converts L-arginine to ornithine. And this effectively mops off the substrate for nitric oxide synthesis. Oxidant-free radicals also reduce the nitric oxide availability. Now, all this would lead to an endothelial dysfunction. In this endothelial dysfunction, there is slow, persistent release of precursors for erection. So with this slow, persistent release of precursors for erection, there is persistent or increased possibility of a sickle cell patient achieving erection from very little stimuli. There's also the mopping up of the Rho kinase, and then there is also persistent release or persistence of phosphodiesterase in the corporal system. And so this tends to prolong the erection. So in conclusion, the most common type of priapism is low flow priapism. It's an emergency, and understanding the pathogenesis is important in instituting early treatment and predicting outcome. Thank you.
Thank you, Dr. Danago. Please stop sharing your slides. Dr. Danjuma Kaba will tell us about evaluation and that. Yes, Kaba, go ahead, share your slide.
Is my slides in view?
Yes.
Good evening, everyone.
Good evening.
To make a diagnosis and evaluation of a patient with priapism, history, physical examination, very, very important. We go to laboratory tests and the radiological investigations. The first and foremost, most important step is to determine whether the condition is ischemic or non-ischemic priapism. Ischemic priapism is suspected when the patient has penile pain or has used a medicine known to be associated with ischemic priapism. Yes, it's good for one to determine whether the patient is a sickle cell disease patient or have another blood abnormality. And when these patients are examined, the penis reveals a fully rigid penile shaft. Non-ischemic priapism is suspected when there is no or minimal pain associated with the erection. It's good for one to determine whether there's a history of trauma or surgery in the perineum. Trauma, to the perineum, there are a lot of spots that are using penile protective devices when it was found that priapism from trauma is common associated with spots. Physical leg will, of course, merely engorged or partially erect. In the lab, complete blood count and sickle cell prep should be obtained to rule out abnormalities of red and white blood cells, as well as platelets. Urine toxicology may be illicit drugs are expected. Just like the earlier speaker has mentioned, causes of priapism, the use of various drugs. Recreational, one dispensed in the hospital. The copper blood specimen may be aspirated to assess corporal oxygen tension and acidity. Blood aspirated from a patient with ischemic priapism, it has been described as crankcase oil-like due to its darkness and viscosity. Whereas specimens from patients with non-ischemic priapism are typically similar to arterial blood. It's important to remember that all cases of priapism begin with influx of arterial blood, and as such, carbonous blood gases analysis, if done early, may be misleading. That is to say, in early phase of priapism, if you depend on the blood gases, penile blood gases, it might be misleading because it may give you similar. Typical carbonosyl blood gases in ischemic priapism, the acidity usually 7.25, saturation is there, you have seen on the screen. Non-ischemic priapism, you could see the saturation is higher, far higher than that of ischemic. And of course, normal arterial blood, we've seen that pH 7.4, saturation can go as more than 90. percent. So this guides us as to likely type and cause of priapism. Yes, radiological, there is a big role play in evaluation of patients with priapism. Color Doppler ultrasound examination of the penis and perineum is the imaging test of choice to assess corporal blood flow throughout the length of the corporal bodies. Patients with ischemic priapism have no blood flow in the cavernosal arteries. Patients with non-ischemic priapism have normal to high blood flow in the cavernosal arteries. An arterial fistula, pseudoaneurysm may also be noted. Here we have seen color Doppler image of a non-ischemic priapism following a saddle injury. Shown is a ruptured branch of the cavernous artery pumping blood to a cystic cavity within the corpus cavernosum, the one jetting upward, surrounded by the translucent area. Yeah, note that is the jet of the arterial blood. The use of MRI, contrast-enhanced computed tomography, and nuclear medicine scans for the evaluation of priapism has been reported, but this test should not be considered standard care. Arteriography may be utilized to precisely localize arterial fistula in non-ischemic priapism. Typically, this is only undertaken in the context of attempted treatment with super-selective embolization of affected vessels. Here, the role of interventional radiologists is employed here. Arteriography may be utilized to precisely localize arterial fistula in non-ischemic priapism. Typically, this is only undertaken in the context of attempted treatment, like I said, with super selective embolization of affected vessels. However, this in our environment is not a common practice because we have very, very few interventional radiology in our practice. Thank you very much.
Okay, thank you very much. Kindly stop sharing your slide. Professor Ago Ngwobia will now go on to tell us about the medical treatment. Professor Ngwobia. Kindly share your slide. Unmute yourself.
Good evening.
Yes, put it on slideshow. Put it on slideshow. Put it on slideshow. You can use the one up after animation. You can see place up. Go up. Yes. Yes. I see slideshow in red. Would you want me to share your slide for you?
Yes, sir.
Then stop slideshow. Stop slideshow first.
Hello, sir.
Yes, I say you can. If you want me to share your slide for you, then
Yes.
stop slideshow.
Yes, I will.
Okay. Okay. Is that? Okay, go ahead. Can you see it now?
Yes, I can see it.
Okay, go ahead.
Good evening, our senior colleagues. I want to thank you for the privilege to be in this very interesting topic. I want to the place my other colleagues have spoken about. Priapism is one of the commonest emergency conditions that confronts the urologist. And it's important that to understand the mechanisms of this condition so as to give patients timely intervention to prevent the complications that arise from this ailment. Priapism may manifest in a patient. I know this one of these variants has been elucidated by my colleague. Ischemic, non-ischemic, or stopping priapism. Non-ischemic priapism is not an emergency condition. However, advances in understanding of the pathogenic and biological mechanisms of this entity has resulted in application of targeted management strategies in handling this condition. Current researches continue to focus on novel drugs to prevent and treat this important condition due to its psychosocial and impact on affected subjects. Future trends in research is exploring potentials for tissue engineering and test research to reconstruct functional penises that have been irreversibly damaged by polymanaged ischemic priapism. Sudden priapism is a variant of ischemic type and it involves repetitive, transient, painful, self-limiting episodes of penile erection. And this starting variant can progress the major ischemic event. So that's actually the major problem of sudden priapism. Because a sudden priapism lasting for less than 3 hours can progress the major event that can result in complications. They've been associated with major hematological conditions, sickle cell disease, process phosphorus deficiency, thalassemia, chronic leukemia, spinal cord trauma, and infections. Management focuses mainly on prevention, and the ideal agent that may be used in prevention of sudden priapism should be effective, should be well tolerated with minimal side effects. Sudden priapism management. Well, if they by full medical history, as illustrated by my presenter, duration of onset, previous attacks, frequency of such attacks, age at onset of the first attack, and patients should be able to find out the triggering factors in this patient. Sometimes fever, cough, full bladder, use of drugs can trigger sudden priapism. Single examination, apart from general examination of the patient, which may show evidence of sickle cell disease fascists. External examination is important as the penis, usually the two corporal components are actually reached, whereas the glans is usually soft. because most priapism are by corporate. My other colleague had talked about laboratory investigation, not much full block say, and differentials because it can be due to economic pilot leukemic condition. Patient count is important. We want to understand the pathology of this disease and to understand that there may be progression to active events, and also to understand treatment of this starting the complication can arise, as well as the fact that he may have recurrent episode in the past. Therefore, it's able to cooperate with the advice on preventive practices. Treatment of these patients. Treatment of these patients. A number of drugs are being used, and they can be classified as drugs. Drugs that can hormonal preparations, and this hormone preparation aim as suppressing the serum level of testosterone, as have been spoken in by progress. Testosterone has an effect on the test of the erectile state, and therefore any treatment that involves preparation should be able to suppress the level of testosterone. And these drugs consist of alpha inhibitors, the alpha type 1 enzyme, or the combination of type 1 type 2. That's the steroids and flexible have been used, and have been found in studies to reduce the recurrent rate of certain priapism in patients. Anti-androgens, bacteremide, and flutamide also have been utilized in patients with certain priapism. Again, it suppresses the receptor of testosterone in the tissue. Ketoconazole, an antifocal agent, have been used, and this drug helps to suppress, inhibit the pathway of androgen synthesis in the adrenal gland. That it is testosterone. Estrogen compound have been used. However, all these agents have the side effects. They are associated with low libido. They are associated with gynecomastia. That this testosterone is more also affected metabolic pattern, like changes in fat deposition in the body, and all of them, the hormonal preparation, are not used in prepubertal children because of effects on growth. Also, in men, adult men who are still wanting to have children, use of these drugs can be a form of contraception. So usually these drugs are not very much used in this patient. Other drugs have been used in prevention of certain priapism, include pseudoephedrine, digoxin, tebutaline, beta-2 agonists, phosphorus 5 inhibitors, ralafil, and seraphin have been used. Gabapentin, an anticonvulsant, antiseptic agent, has also been used in treatments. Modafinil like baclofen have been used in treatment of patients with stuttering priapism. Ischemic priapism management, as it's an emergency condition, and it involves with other disciplines, like the work of pediatricians if it involves a child, hematologists, and urologists. And in these patients, time is of the essence, because delay in relieving of this penile traumatic syndrome can result in complication of erectile dysfunction, and if it's severe, can lead to penile gangrene. And the principle involves pain, acute pain control. Pain control is very important. The patient comes with pain, severe pain. Use of opioids, use of non-sedative agents intravenously. It's important to go at resolving this acute event with the aim of preserving erection, to prevent recurrence, and treating the root cause of this condition. Treatment involves, of course, basically you have an intravenous line, mainly most of the time normal saline, with the aim of hydrating the patient adequately, because the viscosity that occurs in the blood in such patients, especially those with sickle cell disease or chronic myeloid is better with adequate hydration. Analgesics, as we mentioned, opioid, non-sedative agents, is for patient count is important because patient must understand the natural biology, natural history of semi-pregnant that is not. You must be aware so that he will not come back to you, disturbing you because he has lost direction. In an environment, patient come 2 to 3 days after the onset of the pregnant event. They must be very, very aware of the results that can happen. Exercise, use of cold compresses. If this fails, corporal aspiration with obligate irrigation with a symptomatic agent can be used. In use of this agent, it's important to monitor the patient's vital signs, blood pressure and pulse rate. Though among these agents mentioned here, phenylephrine is more specific. But in our environment, because most of the times we may using adrenaline, we must also know the complete bad in patients with elevated blood pressure. Priapism in sickle cell patients may present other as stopping variants, which may progress to the major event. When it's less than 3 hours, potential triggers such as infection, full bladder, dehydration, drugs should be looked into. Medical history is important, especially duration of onset, pain severity, and recurrence pattern, because many of them are patients who had episodes of stuttering priapism before the onset of major event. You must also know such patients who have come in the past with stuttering priapism would have had previous corporal aspiration, so they may still present with a form of high flow priapism. Corporal aspiration is both diagnostic and therapeutic, as have been mentioned by Dr. Carl, by the color and its oxygen saturation of the aspirated blood. Corrective measures in this patient, such as exercise, cold can be used. This patient can be done self-injection of phenylephrine at home. Analgesics. If not occurs, patient should be counseled for preventive treatment. If no resolution occurs, corporal aspiration plus irrigation may be done. In sickle cell patients, second prevention may be achieved by use of high-dose urea and phosphodiesterase 5 inhibitors. Patient with malignant ischemic priapism. These are priapism associated with malignancies have been found in patients with malignancies, or can occur as metastatic secondaries from urologic part, from the bladder, from the prostate to the penis. This case is both urologic and oncologic emergency. And the goal in this treatment is to achieve the tumescence as fast as possible, to reverse fibrosis and achieve erection, as well as to prevent future reoccurrence. Overall aspiration and irrigation can be done, as we talked about, using of saline and also use of symptomatic agents. Hyperhydration, antibiotics, somebody may come with infection because of the concurrent elevation and reduction of immunity. Hyperhydration and antibiotics are given intravenously. Leukapheresis has been used in patients with chronic myeloid, as well as chemotherapy for the malignancy that resulted in the ischemic event. Future trend. Patient with irreversible damage corporal cavernous as a result of ischemic priapism, and who cannot benefit from penile prosthesis. Because when a patient has ischemic priapism, he can have insertion of penile prosthesis immediately on corporal on achieving the two methods. However, when they come late, as we see in the environment, the corporal fibrosis will make it difficult to insert a penile prosthesis. Such patients in the environment who have gone through this problem of penile prosthesis, who may not benefit from penile prosthesis, they are currently for tissue engineered corporal tissue. And this tissue has been done through stem cells, mesenchymal stem cells from adipose penile tissue or use of autologous adipose stem cells. This is actually investigational. Some of the studies also have been done on it, but we are hoping as our knowledge increases, this thing can be done for such patients who, instead of remaining impotent all their life, can have a tissue re-engineered penis that can be used. Thank you for your attention. Thank you for listening. God bless you all.
Thank you, Professor Wobia. Please stop sharing your slide. Professor Wobia, please stop sharing your slide. Okay, let us move on to Professor Ademola Popola, surgical treatment. Slideshow.
Good evening, everyone. I would like to thank the CME committee for the opportunity to be part of this webinar. Talking about surgical management of Priapism, there are things to consider. It's not the first thing to do, as we have been told. The first thing to do is a conservative treatment, one to aspirate, to irrigate, and also to give alpha blockers. The principles of management of surgical management of priapisms, I would like to discuss in this line. One, it needs to be understood that the ischemic priapism represents a compartment syndrome of the corpus cavernosa with minimal or no arterial flow into the penis. It causes time-dependent smooth muscle damage that can result in significant morbidity, including permanent erectile dysfunction, penile shortening, penile curvature, and loss of gout without prompt intervention. So if conservative treatment has failed, one needs to have it behind his mind that leaving this patient without surgical management will result in permanent erectile dysfunction. It's also important to note that the corpus spongiosum is not involved in the priapic process and has a separate blood flow. And there's no danger in most patients with a high flow of ischemia. Indications for surgical management: failure or recurrence after the conservative measures is indication for surgical intervention. Patients coming after 4 hours should have conservative measures, and surgical intervention should be introduced as soon as possible. It's important to take a good history. Patients who have been having priapic process for, say, 24 hours, but you must be able to say that some of these patients have had intervention in other places, which include aspiration, irrigation, and so on. So you need to start counting the 4 hours from when the last intervention, because that's salvage. And then So you don't say, oh, he's been home for 24 hours. You need to, if he has been to another hospital, they've irritated, there seems to be some detumescence, and then he recalls again. So you start counting from where the intervention started. Investigations have demonstrated that the hypoxia and acidosis seen in the priapic penis, even after 4 hours, can result in irreversible dysfunction. So this is very important to note that surgical intervention needs to be considered as soon as possible. I'll just clip this slide. With the priapism, the history is very important, like we have been told, and then you need to do good physical examination. You need to consider whether this is ischemic or non-ischemic. If it's non-ischemic, you observe, because about 60% of them will resolve spontaneously. But with failure of resolution of non-ischemic, you may need to do some investigation like arteriography, and if you find the leak point embolization where it is available, and when this has not succeeded, you need to do surgical ligation of a leak point. For the ischemic priapism, which is where the bulk of our discussion will stay this evening, the aspiration with irrigation with phenylephrine and alpha blocker, if that succeeds, fine. But if it fails, you need to consider, because we already know that a delay may lead to permanent impotence, and you then need to consider how to or abort this priapic process, which then brings in the surgical intervention if all conservative measures are failed. And so you have already said, discuss whether it is ischemic, non-ischemic, very, very important. For the non-ischemic, talked about the treatment. So for the surgical treatment of ischemic priapism, what you need to do is, one, like the anatomy of the penis shows that there are 3 cylinders, the 2 parallel cylinders which stay side by side, the corpus cavernosum, they are the ones involved in the process, whereas the corpus spongiosum is not. And that's why the glands is also usually soft, and the blood supply is different. They are different from that. So what you need to do is, how do you relieve the pressure within the corpora cavernosa, and then ensure that there's continued blood flow? You want to create a shunt between the corpus spongiosum and the corpora cavernosa. And there are various ways to do this. And we discuss this step by step. And there are what's called distal shunts, proximal shunt, and then venous anastomosis. For the distal shunts, we have the one percutaneous distal shunt, which include Winter procedure, the T-shunt, the Eberhard procedure, and the distal open, the Ergorab procedure, the glandocavernosa shunt. For the proximal shunt, we discuss all this in detail. For the distal surgical shunt is the Eberhard shunt, which is created using an 11 blade to stab through the glands into the distal tip of the corporal body. When you palpate the glands, you feel the hard cylinder of the corpus cavernosum on either side. So you stab through the glands beneath. So this is the stab for Eberhard. You stab through it right into under the corpus cavernosum. And with that, you have been able to create a shunt between the glands, which is an extension of the corpus spongiosum, and the corpus cavernosum. You don't need to do it on either side, because the corpus cavernosum, they have links between the two along the midline. So once you have done one successfully, most time that should be enough for you to do this. So this is, and then the other one is the Winter's procedure, which you use two-cut biopsy needle, like the one we use for prostate biopsy, going through the glands penis. You can then go through it and create holes, multiple biopsies in the corpus cavernosum on either side. This also creates a shunt between the corpus cavernosum and the glans penis, which is an extension of the corpus spongiosum. With this, you can aspirate the dark-colored blood, altered blood, and then until you wash out until you get fresh bleeding coming in. With that, you have established a link or a shunt between the corpus spongiosum and the corpus cavernosum on either side. That's the true cut biopsy. It has taken a chunk of erectile tissue just to create the tunica, apogenia, and so on, to create a link between them. The elbow edge is you use a size 11 surgical blade, the scalpel, go through and you puncture through the corpus cavernosum on either side. And with this, you have created a shunt between the corpus spongiosum and the corpora cavernosum. You do the same thing. You evacuate the blood, the altered blood, and then wash out, and then you dress. For the T-shunt, you use a size 10 blade. And what you do is, just like the elbow with the elbow, but in addition to that, you rotate the blade. Once you get to the hub of the blade, you rotate laterally, avoiding the urethra. You rotate it laterally. With that, you'll be able to create a T-shaped incision on the glans penis. This seems to be better than the elbow edge. It creates more room, more passage between the corpus spongiosum and the corpus cavernosum. So the other one, which is the open part of the distal shunt, and the commonest one is the head grab. This has been used very well, and also from Zaria, it's been used. It was found to be very successful in treating patients with sickle cell disease who did not respond even to as medical or conservative management. What is done is you make an incision, a curved incision on the glans penis, on the ventral dosum of the ventral of the glans penis. After you have made the incision, dipping it down, you'll be able to palpate the hard corpora cavernosa on either side, those two cylinders. And you take a disc of tissue from there, try to probe inside and evacuate the blood. With this, you have created a shunt, and then you suture lightly with a continuous suturing. You suture the incision on the glans penis. This is the open type of the distal shunt. With this, just like the picture shows, you have created, you're taking a disc of the corpus cavernosum on either side. You can do on one side, but you can also do on either side. As you can see in the picture below, a shunt has been created. Blood flows through the glands of corpus spongiosum and through the corpora cavernosa on both sides. Yes, the proximal shunts. Well, these were used long before people started using the distal shunts. And because of various complications and also the technicality of them, they are not as favored as the distal shunt today. There are three types which have been described. Quackles, which is the perineal approach, an incision in a patient in the lithotomy position. An incision is made in the perineum to get to the bulb of the penis. And with the bulb of the penis, a shunt is created between the bulb and each of the corpus cavernosum. A modification to that is the Sacha one, which is the penoscrotal incision. Instead of making it at the bulb, the incision is made at the penoscrotal junction, and it's made at the penoscrotal junction, and the shunt is created at that point. The advantage of the Quackers over the penoscrotal, the Sacha one is one, the bulb has a lot of spongy tissue, corpus tissue at the bulb, and also the urethra is far away, even from where your incision is going to be. Unlike Sacha, where the urethra is very close by, and the risk of ureterocutaneous fistula is higher. The Odello procedure, which was popularized by Professor Ezekiel Odello in Ilorin many years ago, in 1988, I assisted him in a number of these procedures many years as a resident. He initially was doing the Quackers procedure and then found, the Sacha procedure, and then discovered he had complications which included ureterocutaneous fistula, and then decided to, because the suturing pulled the urethra along because of the thin corpus spongiosum at that point. So he then decided to harvest the savernous vein to patch, to add as a patch on the, on the anastomosis. He is the vascular surgeon, so it was easy for him even to harvest the saphenous vein and graft to be able to patch this anastomosis. This is the Quacker's procedure. This is the bulb of the penis, the bulb, and then the corpus spongiosum on cavernosum on either side. We have created an incision. There is a noise from the background. It's created an incision into it and suture these two together. So what Odelewo did on this was, in addition, he put a venous graft on this. Instead of bringing these two ends together, he put a venous patch over this, like a rooftop anastomosis. So this is what he did to increase the space and also to reduce the tension on the shunt. So the other thing which has also been done is to increase an anastomosis, a venous anastomosis between the cavernosum and also the and various veins. One that has been done, popularized by Grahak, is the saphenous vein cavernosal shunt. The greater saphenous vein is mobilized as far as a good length of it is mobilized, and then tunneled through the thigh to get to the penis. An incision is created on the corpus cavernosum, and this vein is anastomosed even to that incision on the corpus spongiosum on one side. You don't need to do the two sides. You don't need to do the two sides. Okay, you don't need to do the two sides. So this is a savernous vein cavernosal shunt. And the other one that is the other venous cavernosal shunt is the Barry anastomosis. This Barry anastomosis takes the deep dorsal veins and anastomosis to the corpus cavernosum. You can deglove the penis or make an incision on the penis. Degloving may be easier and with better cosmesis. Take the deep venous vein on one side, ligate it, divide and ligate, and one end of it is pumped to anastomose into the corpus cavernosum. There are complications from surgical management, and one is erectile dysfunction. I have seen some with failure of closure of the shunt. That leads to washout whenever the patient has intend to have erections. The erection is not sustained because the shunt still remain patent, and this leads to erectile dysfunction. The other one is ureterocutaneous fistula, like it's been especially with the proximal shunts. There are reports of fistulae, and one of the reasons why Odelewo introduced the venous patch was incidence of ureterocutaneous fistula from that procedure. And since they introduced the patch, there was no ureterocutaneous fistula. However, many years after, we have seen patients who had the Odelewo modification who came with erectile dysfunction because patients could not sustain to keep blood within the corpus cavernosum. There could also be denervation when you are doing this surgery, which leads to decreased sensation on the penis. The proximal shunt and the distal shunt, when you compare them, erectile dysfunction is commoner with the proximal shunt. Ureterocutaneous fistula also is commoner with the proximal shunt. Proximal shunts take a longer time and they are more invasive, considered like harvesting venous, saphenous veins, and also degloving the penis. They are more invasive than the distal shunt. For most patients, like was presented in this area, most of their patients who had the health corrupt they did very well. The sickle cell patient who had Egora did very well. So it is encouraged that more people should do more of the distal shot. And one of the surgical procedure which needs to be done for erectile dysfunction, which I believe will be discussed by Professor Martama, when patient has developed erectile dysfunction from spongy fibrosis, there may be need even to start benign prosthesis. I think this will come up more in the next discussion. Thank you very much.
Thank you, Professor Bola. We will now take Professor Maitama. Professor Maitama, begin to share your slides, please.
Please, can you see my slides?
Yes, put it.
Can you see my slide?
Yes, but put it in slideshow.
It's in slideshow now. The moderator knows CME committee. Let me congratulate you once more and thank you for the good work. As we have heard from various speakers, the topic is a very hot one. But what is it? Priapism. Priapism is a form of partial erection that continues more than 4 hours beyond sexual stimulation and orgasm, or is unrelated to sexual stimulation. We must understand that it is a disaster to have priapism. It's disaster because you cannot take away what you cannot give. Even though it's classified as ischemic and so on, the complications are related to the duration, the etiology, the type, and the initial management. But whatever we do in managing priapism, what do we want to achieve? Is resolution, return of sexual function in the absence of medical and surgical adverse events. So priapism and its complication arising may be treatable and preventable. There are certain complications that we are unable to assess because the management of complications of priapism is multidisciplinary. It's better not to start than to start it because no one knows the end of what you are going to do. You have the psychological, you have the functional, and you have the structural. So the psychological aspects, the heartbroken, depression, and person knowing that before he can do this, now he can no longer do it, especially for those that have been enjoying coitus from the beginning and now having this problem. We must also remember that when we are treating people for erection, priapism, the treatment itself is going to end up with complication of the priapism itself, that is erectile dysfunction. So we must be careful how far we are going, what we are giving to the patient, and how we think the patients need. We understand that treating priapism requires time. So the earlier, the better. Previous speakers talk about these patients coming 4 hours, but it's not just 4 hours. It is said that how long are you going to take to achieve the tumescence? So if you are going to spend more than 1 hour investigating the patient and achieving the tumescence, that means by then smooth muscle ischemia and necrosis might have taken place. Studies show that by 48 hours, smooth muscle necrosis and irreversible changes have already occurred due to ischemic changes. So therefore, emergency medical intervention that is required must minimize these consequences. So therefore, when we want to take care of these patients, then we must be very, very careful, because once you intervene, the patient will say, since you operated on him, he has not been having erection again, and he'll be coming and coming and coming to you. So it must be clear that this patient must understand and he must sign, and there must be a witness. So that is very, very important. Penile MRI can be done to show viable smooth muscle. Once this is visualized, then you have the hope that erectile function is going to be recovered on clinical follow-up. But once shows that smooth muscle is non-viable, plan for early prosthesis. That is important. Need to monitor patients. It is important that common etiological factors such as hematological dyscrasias, neoplastic syndromes, sickle cell disease, and severe pharmacological events, we must be careful as starting treatment, and we must document everything, even though most of this problem occurs in sickle cell disease participants. But many of the patients are carriers and they still have same. But those that have been having it during childhood, most important is the pain. So second generation antipsychotics, other medications account for greatest percentage of published drug-induced priapism cases. So isolated cases of priapism have been described in men who take PDE5. Please, can you hear me?
Yes.
Hello?
Yes.
Go ahead.
Thank you very much.
Prof.
Thank you very much. Malignant priapism could arise either from metastatic original infiltration by tumors of the bladder and prostate. Although these are rare, but we must pay attention that in this case, the priapism that occurs must be targeted towards the tumor management until proven otherwise. Pharmacological treatments in this case are unlikely to be effective. So penile MRI assess the viability of corpora cavernosa, presence of penile fibrosis. In particular, cases of refractory priapism or delayed presentation, smooth muscle viability can indirectly be assessed. So supportive care and medical intervention for primary cancer is important. And in selected cases where palliative options fail to control pain, then palliative phallectomy can be considered. Complications of medical treatment. The commonest complication is sexual dysfunction. The patient is now feeling that he's different. And the responders, because of the concern, and also is something that they will not make public. So they stay long with this problem. Therefore, they don't report it until when it is extreme. First line treatment initiated beyond 48 hours, while relieving priapism, have little documented benefits in terms of long-time potency preservation due to irreversible smooth muscle hypoxia and damage that begins to be established by approximately 48 hours of onset. So when they come, please don't stay and play. Just go ahead. Second-line treatments can be considered when conservative management options fail. That means a period of at least 1 hour of the first-line treatment without the two missings. So gadolinium enhanced penile MRI and carbonosal smooth muscle biopsy done to diagnose smooth muscle necrosis. If present, shunting is likely to fail. So you need to consider the patient for immediate penile prosthesis insertion. Erectile dysfunction. Erectile function following prolonged episode of priapism are low and are directly related to the duration of the priapism, preoperative erectile status, and the age of the individual. If ischemic priapism resolves within 24 hours of onset, it has been reported that 78 to 100% of patients regain spontaneous functional erection with or without PDEs. In contrast, other studies have shown that priapism for more than 36 to 48 hours appears as a result of both structural and functional effects on corporal smooth muscle with poor outcomes. So in these cases, erectile dysfunction is more than 90%. Shunt procedures undertaken after 36-48 hours may only serve to limit pain without any benefit, without any beneficial effects on erectile function. An early prosthesis insertion should be considered in these cases. Use of antithrombotic agents. Shunt procedures may further delay penile prosthesis insertion with detrimental effects on surgical outcome. These patients tend to have penile shortening and prosthetic infection when undertaken because of these delays. Procedures for shunting require incision through the tunica albuginea and exposure of collagen to coagulation factors in the penile blood, and thus activate blood clotting cascade. So perioperative anticoagulation is advocated to facilitate resolution of the priapism. Periprocedural antithrombotic treatment with 325 milligrams of acetyl salicylic acid preoperatively and 5,000 international units of heparin intraoperatively and post-operatively continued for 5 days. We should also add 75 milligrams of clopidogrel to decrease priapism recurrence. This has been successful in 84% of cases. Shunts, algorab, an incision made transversely on the glands may compromise arterial flow because distal deep dorsal arteries run longitudinally in the glands. So one has to be careful, or else you end up with more complications than priapism, may end up with penile loss. The Bennett technique, the so-called snake maneuver, is a modification of algorab. But this one is more invasive, so wound infection, penile skin necrosis, and ureterocutaneous fistulae are common. Open proximal corporal spongiosal shunt, either the quercus, unwanted ureterocavernous fistula, and urethral stricture and cavernocytis are common. So we are now exchanging problems with problems. The risk of urethral injury is less with perineal approach because the bulb protects the urethra. But these proximal shunt are more invasive and ED rates are documented to be higher. So venous anastomosis procedure complicated by venous femoral thrombus formation and by pulmonary embolism. Immediate penile prosthesis insertion is recommended in this case. Refractory therapy resistance, acute ischemic priapism, or episode lasting more than 48 hours usually results in complete erectile dysfunction. Possibly, along with significant penile deformity in long term. In these cases, immediate penile prosthesis surgery is advocated. Early penile prosthetic surgery, the immediate insertion of a malleable penile prosthesis, avoid the difficulty and complications of delayed prosthetic surgery in the presence of corporal fibrosis. This is hell. If you are to do this surgery with corporal fibrosis, you will not like to repeat it again because the bleeding is enormous and the anatomy is completely distorted. So potential complications are distal erosion, infection, and revision surgery. So we keep revising the surgery because of complications. So early surgery also offers opportunity to maintain penile length and girth and prevent penile curvature due to cavernosal fibrosis. The prosthesis can be exchanged for inflatable prosthesis at a later date, which may allow upsizing of the implant cylinders. Relative indications for prosthesis: ischemia that has been present for more than 48 hours, failure of aspiration and symptomimetic intracavernous injections in delayed priapism, magnetic resonance imaging or corporal biopsy evidence, corporal smooth muscle necrosis, failure of a shunt procedure, although it delayed in cases, implantation might be considered ahead of shunt surgery. Refractory priapism in patients who are undergoing shunting procedures. Automation. This has to do with time. What do you want to do? When are you doing what you are doing? So the optimal time for implantation is within the first 3 weeks from priapism episode. If shunting surgery has been performed, penile prosthesis implantation can be further delayed in order to allow reduction of edema, wound healing, and risk of prosthetic infection. A vacuum device to avoid fibrosis and penile shortening may be used during this waiting period. The decision on which type of implant to insert is dependent on patient suitability, surgeon's experience, and availability and cost of the equipment. Efficacy and complication rates of malleable and inflatable penile prosthesis. Well-motivated and counseled patients prior to the procedure, immediate inflatable penile prosthesis implantation may be undertaken. In most cases, a semi-rigid implant is more suitable as it is easier to implant and reduce operative time and hence risk of prosthetic infection. The patient must begin cycling the device immediately to avoid a fibrous capsule forming and contracting. Early cycling of an inflatable penile prosthesis prevents penile curvature and shortening, infection, erosion, and mechanical failure. Surgery for non-ischemic priapism. Here, structural changes, cavernosal tissue necrosis and fibrosis with consequent penile scarring, megalophalic deformities, penile shortening, and occasional penile loss. Erectile dysfunction, successful first line or second line treatment in the tumescence of the penis. Penile prosthesis implantation is occasionally indicated in sickle cell disease patients with severe erectile dysfunction. This is what we recommend also in our center. We do patients with that have stuttering and recurrent of such injections are avoided as they may provoke further priapism. In severe corporal fibrosis, narrow-base prosthetic devices can be implanted. In penile destruction with complicated deformities or even loss of penile tissue, it may require multiple corporotomies, corporal excavation, optical corporotomy, the shear technique, dilatation with carrion, Rosello, cavernotomy, Uramix, or mobile cavernotomy. Excision of scar tissue and use of small diameter prosthesis or penile reconstruction using grafts. Complications of non-ischemic priapism. Non-ischemic priapism is not an emergency because corporal cavernosis does not contain ischemic blood. The duration of non-ischemic priapism can also impact erectile function. Erectile dysfunction or distal penile flaccidity. So treatment here, conservative measures such as selective arterial embolism using autologous blood clots and gel forms or permanent substances such as microcoils, or use of ethylene vinyl alcohol copolymers and N-butyl cyanocryolate. Complications of management are risk of erectile dysfunction and stroke recurrence rate. So the management may fail and recurrence are high. Penile gangrene could occur, or gluteal ischemia, cavernocytis, and perineal abscesses as a result of use of this selective embolism and most of these conservative measures. So surgical ligation of fistula when there are contraindications for selective embolism. But if embolism is unavailable or repeated embolisms have failed, then you carry on with this ligation. But note, erectile dysfunction is up to 50% of cases. High flow priapism in children. Non-ischemic priapism in children is rare, and the etiology, clinical presentation, and diagnosis, as well as therapeutic principles, are comparable with those of arterial priapism in adults. Thank you, ladies and gentlemen. Thank you, Naus.
Yeah.
Thank you.
Thank you.
So, Professor Al Hassan, take over.
Yes. Thank you all. I thank the presenters and also the organizers. I'm just going to run through a brief summary of the presentation, even though the first presentation I was not having audio, but from what I could gather from the screen, Inkem Dilim Okonji presented on made an introduction and also anatomy of the penis, and she classified the priapism into three: ischemic, non-ischemic, and stuttering. And I told us the origin of priapism from Priapus, god of fertility. And then, so we have heard about extensive anatomy of the penis and how it can lead to priapism. Then Dr. Diana Gogo presented epidemiology and pathophysiology of priapism, ischemic or low-flow priapism, which he classified, in which sickle cell disease, hemoglobin SC disease, thalassemias, and other thrombotic diseases, as well as G6PD deficiency. And he and sickle cell disease. Then he also elucidated on the molecular basis of ischemic priapism, which he outlined from imbalance of vasoconstriction and vasodilatation, as well as the role of tumor growth factor beta upregulation, leading to damage, smooth muscle damage. And in sickle cell disease, priapism occurring as a result of deficiency of nitrous oxide, which is converted into an inert form. And also there is a decrease in nitrous oxide with hemolysis leading to priapism. The next is Mark Calver, where he gave us a rundown on the process of evaluation of priapism, which involves history and examination, in which the presence of pain or presence of trauma in the perineum, and also to determine whether the patient is a sickle cell disease person. And also, we will need to do urine toxicology to find out if there is drug abuse. And you take oxygen saturation in the aspirated corporal blood and its acidity. The oxygen tension in the aspirated blood determines whether it is ischemic or non-ischemic. And then color Doppler will also show the blood flow, and other radiological imaging like MRI is used to identify muscle necrosis, and you may intervene using arteriography, where embolization as a form of treatment can be done. And then Ngobia Peter Abu from Sokoto, he outlined the medical management of priapism. It started with stuttering priapism, in which hormonal manipulation to reduce the serum testosterone using bicalutamide, sildenafil dutasteride, as well as ketoconazole. Medical treatment in different groups also, ischemic priapism, sickle cell disease are classified as. In sickle cell disease, you have high flow priapism, in which he indicated the usage of phenylephrine to counter the tumescence. Malignant ischemic priapism, the medical treatment is that of adequate hydration aspiration, leukapheresis, and treatment of the malignancy. And the future trend is that of deciding on this patient early to have prosthesis and also tissue engineering as well as stem cell treatment. Professor Ademola Pupola, he outlined the surgical treatment of priapism, ischemic priapism, which is a form of compartment syndrome. The indication for surgical treatment is generally failure or recurrence after conservative treatment. And he has said any priapism that is more than 4 hours should have surgical treatment as soon as possible. And the non-ischemic priapism usually resolve, 60% of them resolve spontaneously. Now, the ischemic priapism, the intervention is to aspirate and irrigate the corpus cavernosa with phenylephrine, and as delay will lead to permanent impotence. Other modalities of treatment are shunts between the cavernosae. You could do distal shunt, the L-Gorap, using true cut needle, 11 blades, or size 10 blades for T-shunts. The proximal shunts, which he outlined, mainly 3, the Cockles, the Sacha, and the Odewale, a modification of the cavernosal shunt, with the aim of achieving detumescence. Proximal shunts are usually more complicated. Now, we were treated to complication by Maitama. The treatment of complications, he said, malignant priapism is the treatment of the malignancy. The complication from medical therapy, especially if delayed for more than 8 hours, leads to erectile dysfunction due to cavernosal fibrosis and smooth muscle damage leading to this fibrosis. Erectile dysfunction usually occurs if there is delay of treatment for more than 48 hours and above. And surgical treatment is only useful to alleviate pain. Early penile prosthesis is recommended, and currently, nowadays, penile prosthesis is recommended early for priapism in sickle cell disease. And the prosthesis itself has its own complication, that of distal erosion and infection. And so generally, in general, these are the 6 presentations by the different presenters. And I think they have done a wonderful job to priapism. Thank you.
Okay, thank you very much, Professor Al-Hassan. We will take the questions, and the president, the chairman of the CME committee, Professor Azudu, will address us. So there are a few questions. So please, one is, okay, somebody said he wasn't seeing the slide well. Maybe it's the way you set your app. Then he said, what is the average cost of penile prosthesis in Nigeria? I think that should be Maitama. Maitama, can you address that? What is the average cost of penile prosthesis in Nigeria? Isaiah, unmute yourself, respond.
Thank you very much. I can see that you have unmuted me now. Yes,
Yeah.
the cost depends on which type of prosthesis. But if the patient is going to have the malleable, he is going to spend an average of 3 million.
Okay.
Thank
About
you.
3 million.
Yes.
Okay. Now the other question. He said 3 million, but it depends on the type of processes. Professor Ahassan, you may unmute yourself with me. Now, the next question is, what is the role of ketoconazole and sildenafil in management of priapism? What is the role of ketoconazole and sildenafil in management of priapism? Professor Ngobia. Professor Ngobia, please, what is the role of ketoconazole and sildenafil?
Yeah.
Please, the people that have presented before, please don't omit yourself so that you'll be able to respond to the questions. Professor Ngobia. Unmute yourself and respond to the question. The next question is.
Hello, sir. Can you hear me, sir?
Yes. And please don't mute yourself again. Don't mute yourself again. Okay, go ahead.
Yes, sir. The ketoconazole inhibits fractional androgens. So it can be used in prevention of certain priapism. But also, sildenafil also works on the smooth muscle. It is the tone of the smooth muscle. So both of them are used. Ketoconazole have an anti-androgen effect. So they're not very good in children with sickle cell disease because of the risk of what they have. Thank you, sir.
Okay, still to you. Any role for regeneration medicine in late cases?
Yes, I mentioned the role of stem cell research in patients who have irreversible corporal fibrosis and who cannot have penile implants. There's a place for it. But all these are still investigational.
Okay, with regard to, yes, with regard to our local setting, where most of the patients present beyond 4 hours, we need to offer processes early as part of the prongs of management as we cancel. Where are the, sorry, somebody just sent a message. Okay. So you're saying in our local setting, where are the centers where patients can access this service, the service of penile prosthesis? Which centers? Yes.
I think Zara do something on it, not us in Sokoto. We're not doing it in Sokoto yet. Zara is doing penal process insertion.
Okay. Another question. Please, for men, for patients who are offered penal processes, what is the guarantee for sexual satisfaction for the men? Maitama. Maitama. Demola. Yes.
Yes, the role of sexual satisfaction in men who have had stasis. It would not likely going to be like the natural one, but with preservation of some of the nerves. The fact that you are able to satisfy, at least your partner can get some satisfaction. It also gives you satisfaction. Because if you are married, you have a partner that you cannot have sexual intercourse with. That's a distress. That's enough distress. But the fact that you can satisfy your partner, that's one satisfaction. And then two, and I believe you can also get some sexual satisfaction with preservation.
Okay, sir. Thank you. Thank you. Please, can I respond now?
Go ahead.
Thank you very much.
I have it from Priapism. He had this approximation.
Okay, when you finish, I can.
Yes. Go ahead, Demola.
He had this proximal shunt and could not have erection, but stimulation from his partner, manipulation of his phallus by the partner also gave him some stimulation to the fact that we are trying to tie off the fistula which he had from as a complication of the proximal shunt. But man was able to ejaculate with just stimulation by his wife. And what we did was to collect the semen into a syringe anytime he ejaculated from stimulation, and he was able to impregnate his wife with that. And that gives some satisfaction, at least reduce the pressure on them. But I believe with prosthesis, some patients will get some satisfaction. I think Professor Maitama, with some experience with penile prosthesis, is about to come on.
Okay,
Professor
Maitama.
Thank you, Prof. Pokola. Thank you very much. What you said is true, but in this regard, the coitus is for the partner, not for the patient. The patient is able to do just to satisfy the partner, but he may not have any sexual stimulation or feeling. He can be able to impregnate the partner by ejaculating inside the vulva, but it may not have any arousal or feeling of satisfaction that he has had intercourse, unlike when things are normal. So therefore, it is done and aimed at the person satisfying that he has an erected penis. His penis can erect. So that is that's the satisfaction he's going to get, that at least something is erectile is with him. And each time he wants it erect, he can erect it. And then each time he wants to have coitus, he can direct it and have it done. So depending on which type he has, whether the malleable or he has the inflatable. So the inflatable is closer to the natural. So that one, at least he can pump it up and then he can deflate it, as compared to this semi-rigid, where he now directs it up, side, down, and so on. But that is what he is going to achieve. Thank you.
Okay, there's another observation. This has not been treated. How long does one observe non-ischemic priapism before instituting intervention? Since 60% resolve spontaneously?
Thank you very much. For observation, the first thing one need to ensure, you must ascertain that this patient actually has a non-ischemic priapism. That's the first thing. And then for how long you wait, you may not be able to put a time, but you must notice that there's a progressive reduction or there's resolution of the priapism. There's no pain. And then you may also monitor using doing arterial blood gases venous blood gases collecting from the cavernosa. And once it's getting better, you may need to worry. It may take some time, but you cannot put a time to it because the fistula will vary from the sizes and also the number of fistula. Thank you very much. So it's just something you need to continue to observe. But the first thing is to be sure that this is a non-ischemic priapism.
Okay, thank you very much. There's another question from Abubakar. What is the role of exchange blood transfusion in the management of priapism? Professor Ngobia, what is the role of exchange?
Thank you so much. Well, in our center here in Sokoto, we don't use exchange blood transfusion in management of patients with priapism. Even the patient try to do it, we don't do it. We don't do it. At most, for those who aspirate, if they call us, or if it's not resolving, we'll do distraction.
Okay. There's a comment from Ibope. Penile processes infarction in patients with cavernosal fibrosis is a rather difficult process. So, and what we should emphasize is some preventing and also early intervention. Okay, from the clinical standpoint, when you do penile aspiration, do you stop and offer the patient a distal shunt? Also, what parameters do you use to determine which of the shunts to use? Demola.
Okay, the first thing to note is better one, what you are used to doing. The distal shunts are better to do. What you are used to doing, I do echo wrap when I need to do, and that's what I've done most of the time. But you can also do winters, which is also easy to do with the Tuchel biopsy needle. I think it varies from what you are trained to do, but most of the distal shunts are easy to do. But the proximal shunts, if you have recurrent failures from distal shunt, you may consider doing the proximal shunts. But they are invasive, they are more technical to do. But like I said, we did a number of the proximal one with the other lower modification using saphenous graft, but I haven't done one myself. But most of the patients that I've done have been egg graft, and they've been almost 100% success with that. So I think nowadays most patients will do well with the distal shunts.
Okay, please, is there any prophylactic option for stuttering priapism? Any prophylactic option for stuttering priapism? Professor Ngobia.
Yes, sir. We are mentioning use of hormonal preparations, hormonal manipulations, the antiandrogens. We also mentioned the use of low dose of sildenafil. Some are used 25 milligram on daily basis, while they use 5 milligram of tadalafil 3 times in a week. Also, people have used dutasteride or finasteride, and they have been found to reduce the frequency of stuttering priapism in these patients.
Okay, very good.
Thank you, sir.
It looks as if I've taken most of the questions. I've taken most of the questions. So please send your name and your email to our chat box so that you will be able to get the we'll send the CME points. So please send your name and then your. So I will hand over to Professor Al Hassan to make his comments, and our chairman of CMA committee. Okay, there's just one. Okay, I've seen that. So please send all your emails, please. Professor Al Hassan, back to you.
Yes, I just want to thank the NAUS for organizing this quarterly CME event. It's very good for students, and it's very informative, and you bring experts from different parts to participate. And I thank also the participants for a well-researched, well-documented presentations. Just one point to add to what Dr. Ibope said on extensive fibrosis for the insertion of the prosthesis. Usually you have to dilate. Naturally, all those who have erectile dysfunction from in the corpora cylinders, whether malleable or inflatable. And I also want to offer information. This is in American Teaching Hospital, but only the malleable. The inflatable can be quite costly. It's about $12,000. It's effective, but it's quite expensive. And I think last time there was a presentation that was by one of the series on it, and he indicated it was $12,000. The malleable one is about yes. So over to you, to Professor Keke.
Okay, thank you very much. For the chairman to make the final comments, please, I've seen just 42 people that have sent their email. So please send all your email address or your names. And then this presentation will be uploaded in our YouTube channel this night. And also the link will be sent to the WhatsApp those platforms, so you can watch it again, video. Thank you, Chairman. Dr.
Thank you very much, Professor Keke, who has been the co-moderator today. Thank you very much. I know what it took you to be able to do this today. I want to thank all the presenters again. You did a wonderful job. Thank Professor Sani Al-Hassan. Thank those who attended. At a point, we had 108 people on the call, but overall, I'm sure we have had a total of up to 120 because people were coming and going. Our next presentation will be on the 17th of June. And we're going to be dealing with management of ureteric injury. and I want to encourage us to block that date and be available. I still have some difficulty in getting presenters, so I will like I've requested earlier, please, if you would like to participate in these webinars, can you send your name and number to me on my WhatsApp so that I can have a bank of those who want to participate, and will be putting you in as and when due, so that we don't keep looking for people to come and make presentation. Make yourself available. We're all urologists, we can talk on most topics, but when we know that people are strong in particular areas, we would like to put them in this area. Thank you very much. God bless you. Good night.
Thank you, sir.
Please, we need more emails so that we make sure you get your CME point.
Hi, Mina, thank you so much. You saved me today. You know.